This conference will now be recorded.
Good evening, everyone, and thank you for coming to our first virtual happy hour. We are the Rehabilitation Treatment Specification Networking Group, and we have been in business for a couple years, so we welcome you. And now I'd like to formally introduce our speakers. I am your host, Susan Lynn. I'm the Program Director at Marymount University's new Occupational Therapy Program, Post-Professional OTD. And Dr. Fasoli, do you want to go next?
Sure, I am Susan Fasoli. I'm a professor at the MGH Institute of Health Professions in Boston. Welcome, everybody.
Hi, my name is Leanna Katz. I'm an occupational therapist, and I'm affiliated with Boston University and Spalding Rehabilitation Hospital in Boston, Massachusetts.
Hi, and I'm Shanti Pinto. I am a physiatrist that specializes in brain injury medicine. I am at Carolina's Rehabilitation in Charlotte, North Carolina.
So we'll go ahead and get started. And none of us has any financial or non-financial conflicts of interest to disclose. Today's learning objectives, we hope that after this presentation, you'll be able to articulate at least 2 reasons why current methods of describing rehab interventions are insufficient or imprecise. Oops. We hope that number 2, you'd be able to apply treatment classification guidelines as articulated by the Rehabilitation Treatment Specification System, also known as the RTSS, to enhance clinical reasoning and critical thinking. And lastly, we hope you'll be able to reflect on opportunities to implement RTSS for documentation and communication purposes in research, education, and in practice. We're going to get into a case study that we will refer to throughout the beginning part of this presentation. So our case study today is a woman named Phyllis, who is 64 years old, and she is a retired school bus driver. She enjoys walking, eating out at restaurants, spending time with her grandchildren, and she was recently diagnosed with acute respiratory failure complicated by sepsis, resulting in a 20-day-long ICU stay, followed by 3 months in a long-term acute care hospital. So we have a PT example because later on we do have an OT example, and there are some speech therapy examples embedded throughout, so we want to represent the whole rehab team. So a PT goal for Phyllis was to, long-term goal is to ambulate at least 150 feet on level indoor surface with modified independence using the least restrictive assisted device. So in order to reach that long-term goal, the physical therapist is working on various therapeutic activities with Phyllis. So some ideas for therapy treatment that Phyllis can participate in order to achieve that goal include lower extremity, passive range of motion, or active assisted range of motion, the use of the Moveo, which is like a traditional tilt table with the ability to also include active exercises, sit to stand training and step training with body weight support, followed by sit to stand training and step training without body weight support, the stationary bicycle and continuous movement for continuous exercise, pain management in the lower extremity, and then walking various distances with various devices, starting with a walker, then a cane, and then progressing to handheld assist.
So
Perhaps
there are many aspects.
I'm just wondering if we could ask people to please mute their microphones if they haven't done that, so that we don't hear distracting noises. Thank you. Sorry, Shanti.
So there are many aspects from thinking about the way that we provide rehabilitation services to our patients. You can think of it very globally in regards to the entire system of care, and then start thinking about the individual rehabilitation program that is provided for the patients overall, and then also breaking it down into the care of the patient. When thinking through the care of the patient, a lot of times you think about your assessment, such as in this case, the patient is very weak and deconditioned from a prolonged hospital stay, And then also think about your indirect outcomes or what your goals are, such as being able to ambulate. But what we really want to do is focus on this aspect of the treatment ingredients and the direct outcomes as highlighted in the circle. Next slide. So when thinking about ways to describe the rehabilitation treatments, there are not great standardized ways to do it. And so some ways look at kind of what you need for documentation or coding, such as the CPT codes, describing what you did, what problems you were treated, or how long or how frequent the sessions are. And then there's also discipline-specific frameworks for each of the different disciplines that work with our patients, such as occupational therapy, physical therapy, nursing, and also speech therapy. Next. You can get into some of the reporting guidelines from a research standpoint, and those are listed on the left side. I'm not going to read those out to you. And then also think more in kind of the big, broad frameworks of looking at the patient from a more global aspect, kind of looking at the function, the disability, and health. So the World Health Organization classifications. Next. And again, this puts you into this big black box of rehabilitation because there is not a good standardized way to define or describe rehabilitation treatments. And as a result, we cannot effectively communicate the elements that are producing or not producing the therapeutic change, both in our clinical practice, when we're signing out to different providers, or in research endeavors. Next. So we want to go back to the case study that was described by Leanna earlier. And I want you to sit down and think about the specific treatment. So if you have a pen and paper near you, you can write this down. Think about like what are you focusing on with your goals and the treatments. And really more specifically, kind of identify the type of treatments that are being provided and what the therapist is addressing through these treatments. Next. So we'll give you about 30 seconds to a minute to be able to sit down and think through this case series with that in mind. What treatments are being utilized in this intervention and what specifically is the therapist targeting with these treatments? Okay, and we can move along to the next slide. So I want you to think about the difference between a treatment theory approach versus an enablement theory. So when you're thinking about what the treatment and the intervention is doing from a treatment theory approach, you're thinking about how the intervention directly changes the target. And you're focusing on how those interventions are directly impacting the target and providing some type of a measurable change. Whereas enablement theory, you're thinking kind of more of what the treatment is going to do with the downstream functional outcomes. Next. So again, we're looking at in this talk, we really want to focus on that how the treatment ingredients are changing the direct functional outcome, which is very much the treatment theory approach. Next. And this is a diagram to be able to think through exactly what we're talking about with this. So for example, you have a patient that had a stroke and has right hemiparesis with some spasticity that is developing, and that's causing them to have an elbow flexion contracture and decreased range of motion. So the treatment is going to be stretching the elbow. From a treatment theory approach, you're looking at how am I using this treatment of stretching the elbow to be able to impact the range of motion directly? And this is something that, again, is a very measurable change. You can check the range of motion, prior to the intervention and following it, and you can track it over time. When you look at it from an enablement theory approach, you're looking at if I do this stretching of the elbow, my long-term goal is to be able to get the patient to be able to dress more independently. And so you're kind of taking the step of more of this broad picture and this broad goal rather than focusing on the direct measurable change. Next. And both of these theories are very important for both treatment and research. And again, to highlight the difference with the treatment theory is that you're looking at the active ingredients and how it's impacting that measurable change. And again, with enablement theory, you're looking at how am I using this intervention to improve some type of physical or cognitive function, and then you're going to take that intervention to be able to look at the functional outcomes that are a little bit more further downstream and impact them. And like I said, both are very important to look at for treatment and research. Next.
Okay, so now I'm going to talk about the RTSS, the Rehab Treatment Specification System, and to give you an overview of how this is used in terms of treatment theory, as described a little bit by Shanti. So the Rehabilitation Treatment Specification System is a conceptual framework to specify rehabilitation treatments by connecting clinician actions, or what we provide during our therapy, or those ingredients, with predicted changes in functioning or targets. That the RTSS provides us with guidelines for specifying a treatment that's based on the underlying treatment theory, as Shanti was talking about, and thinking about why or how a treatment works. The RTSS uses treatment theory explicitly to specify the treatment components of a rehabilitation treatment. And we'll talk much more about this as we go along. Next. So when we're thinking about what is a treatment, so a rehabilitation treatment is comprised of one or more treatment components per the RTSS. So each treatment component has a tripartite or three-part structure. This structure includes the direct target of intervention, those active ingredients are what the clinician does, and then the hypothesized mechanism of action, why we think that those ingredients will actually have an impact on our target. Why or how it works. And so these pieces are defined, or these components are comprised of this treatment theory that underlies each treatment component. Next. So when we're thinking about this tripartite or three-part structure, if you're thinking about the process of treatment specification, we actually, as clinicians, start thinking about the treatment target on the right-hand side of this diagram. So thinking about what is that aspect of functioning that I directly want to change with my patient or client. And then we go through this process of then selecting the ingredients. What is it that I am going to provide to that individual that I think is going to have a direct impact on the target? And I select those ingredients based on my treatment theory of why I think that specific treatment is going to work. So this process of treatment specification really starts with this target, identifying the target and working our way through to ingredients. Whereas if we're looking at the causality or the effects of our intervention, then we're looking at, well, how are these ingredients actually having an effect on our targets? And that this process then of looking at treatment theory is different from enablement theory. And it's a different process to explain, but we need to understand those direct components before we can then look to see what are those downstream effects. Next. So all of this will help us to think more cogently and more explicitly about what we do in rehabilitation by paying attention to our choices when we're selecting our treatments. It helps us to better communicate what we do in rehab to our colleagues, to our students or trainees, and to the people that we serve, to our stakeholders. And it allows us to more precisely and effectively study these relationships between what we do in our interventions and the outcomes that we achieve, so that we can actually figure out more explicitly sort of what works and why it works, so that we know for our next patient or client what it is that we need to build into our intervention. It also helps us to certainly improve the quality and effectiveness of rehabilitation, because we're making this process explicit rather than using a trial and error approach at selecting ingredients for our interventions. In thinking about treatment targets then more specifically, remember, as Shanti said, the target is that aspect of functioning that is directly hypothesized to be changed by our intervention. In principle, the targets are always observable and measurable, because otherwise we would have no way of knowing if the selected ingredients were actually working. Next. So when we're identifying targets, they're not the names of problems or impairments, but they're measurable aspects of these. So instead of an impairment or problem with gait, the target could be achieving faster gait speed over a certain type of surface. Or instead of social skills training, that we would have a focus specifically on the target of improved eye contact or turn taking during conversation. Next. So when we look at this comparison between targets and aims, you can see on the left-hand side that targets, again, are those direct aspects of functioning that are affected by your intervention. They have a more immediate result in that they're identified via treatment theory, why you think this particular ingredients are going to have an effect on your targets. Whereas aims are those downstream effects of treatment, as Shanti said, that they're the aspects of functioning that are changed indirectly via changes in other areas of functioning, as was in her example of improving elbow extension or range of motion to improve dressing abilities. That those aims are identified via enablement theory. Next. So a couple of other examples about targets and aims are here. So one target may be increased ankle range of motion that's achieved via plantar flexor stretching. And so that target of increased range of motion helps us to achieve that aim downstream of improving walking abilities. Another example here in terms of targets is palmar and finger muscle strengthening to increase grip strength. So the target is increased grip strength with the aim then of improving the ability to stabilize objects with that grip strength during meal preparation. Next. So when we talk about active ingredients then, and moving on, that the active ingredients are those observable actions, devices, or forms of energy that are selected or delivered by the clinician. This is how we're defining ingredients via the RTSS. So the ingredients are those inputs. They're what the clinician does to affect those desired changes in that direct target. And in theory, they are measurable and observable. Next. So ingredients can be a number of things, and I think that sometimes we kind of implicitly don't even think about those ingredients that we provide to our patients. So there are opportunities to practice an infinite number of skills. They can include teaching and training methods, such as thinking about the type of instructions that we provide, the cues that are given, whether we're giving knowledge of performance versus knowledge of performance, knowledge of results feedback, whether we're doing errorless learning or error-full learning, that those are teaching and training methods that are specific ingredients that we're using and selecting. We also may be using motivational aids such as goal setting or persuasion or trackers of progress during somebody's course of intervention, or providing information and educational materials to help improve learning and understanding of the importance of our treatments and why we're providing a given intervention. Next. So ingredients can also be aspects of the environment. So how materials are selected and set up prior to a task, that we think about those things. And that is an explicit process that we think about how are we going to set up our intervention when our clients are coming into our rehab clinic for the first time. We consider whether we are deliberately providing distractions and whether peers or other patients are deliberately present or absent to increase or decrease the amount of distraction and the amount of attention that's required during our intervention. Ingredients can also be the devices and external aids that we're providing, whether we're providing wheelchairs or button hooks or reachers or planners to help with organizing their daily routines. And certainly ingredients can also be the instruction and practice of strategies to improve performance. And so we can incorporate devices or aids such as checklists or alarms, etc., to help individuals with memory impairments to be able to get through their daily routine. Next. So in addition to the ingredients that we plan within a given treatment session, ingredients are also planned across sessions. And so those ingredients look a little bit different, and they're listed here on the right-hand side of the slide. So examples of ingredients that are planned across sessions can include dosing, thinking about schedules of practice and the intensity or frequency of the repetitions that we're providing. It's important to consider that amount of intensity or repetition to ensure that we're providing sufficient practice for improvement to actually occur. Dosing includes schedules of reinforcement. We also think about treatment progression in thinking if and in what way and how quickly demands of that treatment need to be progressed in order to maintain that consistent level of challenge. And we know that we need to provide sufficient challenge, that just right challenge, in order to help individuals to progress in our interventions. And then it's also an important ingredient in terms of transfer and generalization, in that we have this deliberate variation in environmental conditions and demands that help to ensure that we're transferring the skills that we're practicing within our clinic session into everyday life at home. And that explicit training needs to be entailed. We can't assume that people will automatically carry over the skills that we practiced. So that explicit training is essential in helping individuals to know when, where, and how to use a new learned routine. Next. So I would be remiss if I didn't talk for just a moment or two about mechanisms of action. So the mechanisms of action really are the processes by which a treatment's active ingredients, as we said, are thought to induce a change in that treatment target. So the tricky thing about mechanisms of action is that often they are not observable or measurable. It must be inferred by the effects of our intervention. So examples can include increased sarcomere length following manual stretching of a tight muscle, or learning by doing as a result of repeated practice of handling small objects. So remember, those mechanisms of action is really our hypothesis about how we expect that treatment to have an effect on our treatment target. Next. So those hypothesized mechanisms of action can be used to help us articulate treatment theories and help us to also examine the effects of specific treatment components. So if Shanti's intervention is more effective than my intervention, if I can break down those treatment ingredients and consider those mechanisms of action, I can understand why her treatment is actually working more effectively than mine is when I'm thinking about those ingredients that I'm delivering. Clinicians often have an implicit hypothesis about those mechanisms of action when we're planning treatment. One example is practice makes perfect via learning. But that explicit focus on articulating those mechanisms of action is really what's needed to help us to drive rehabilitation science forward and to help our students and clinicians to think more explicitly and directly about how they are impacting a person's performance during intervention. Next. So if we go back to the case study very briefly, remember that we have our 64-year-old female who has debilitation after a long hospitalization. The PT goal here is to ambulate 150 feet on this level indoor surface with modified independence. And the therapy activities, as Shanti showed earlier, are all listed here. But when we want to think a little bit more specifically about the treatment ingredients of some of these treatment activities, I'm going to show you the next slide just to give you a little bit more example of how we break down those a little bit more in terms of thinking of their treatment components. Next. So here we have our ingredients, our mechanisms of action, and our targets. So if we think about the ingredient of providing progressive resistive lower extremity exercises to the hip and knee extensors, that we're providing those ingredients or that ingredient to target increased lower extremity strength for sit to stand. And the mechanism of action, why we think that's going to work, is that we know that increased demands for muscle firing will lead to cellular changes that allow for greater force generation, that we have evidence that show us that. The ingredient of providing opportunities for continuous exercise on a stationary bicycle at low resistance is directed toward the target of improving endurance. And we know, again, from our understanding of endurance research and literature, that the mechanism of action for that is gradually increased demands in the cardiovascular system leads to that improvement in endurance. And then finally, the ingredient of explaining the importance of energy conservation technique is directed toward the target of increased knowledge. And Leanna will talk more about these different categories or groupings of targets per the RTSS coming up next, so that improved knowledge of how to pace activities as endurance improves is another target of our intervention, because without that, people are less likely to carry over their interventions when they're not with us in our treatment sessions. And so cognitive information processing is believed to be the mechanism of action for that ingredient and target. So now we're going to move on to Leanna's section on treatment groupings in RTSS. Thank you.
Thank you, Sue. So now that we've covered the treatment components, now we're going to go into the treatment groupings. So the RTSS defines 3 treatment groups that it believes encompasses together all treatments that might be done in rehab and are mutually exclusive as to the kinds of targets they include and the kinds of active ingredients that must be employed to change them. We will go into more detail of each group in just a moment, but I want to introduce the 3 treatment groups here that are each defined by the targets of treatment for which all rehabilitation treatments fall into. So first we have the organ functions group, which includes changing or replacing organ functions. Second, we have the skills and habits group that includes all skilled performance like ADL, leisure, and work. And lastly, we have the representations group that includes all cognitive and affective representations or anything that is internally represented in the brain. Next. So as mentioned previously, we've seen this diagram before. We want to consider these treatment groups as defined by the target of the treatment. So we're starting backwards. We're starting on the right-hand side. So first we want to ask what needs to change. That would be our target. Second, we want to ask how might this be changed, which would be our mechanism of action. And lastly, we want to ask what can I do as the clinician, as the providing clinician, to affect this change, which would be your active ingredients selected. Next. So our first group is our organ functions group. So again, it's defined by the target. So the typical target in this group includes changed or replaced organ functions. So this includes treatments in which the functions of organs or organ systems are modified, or for which the target of the ingredient is to bring function to a desired level through natural adaptive processes. So the latter may include up or down regulation and habituation to repetitive stimuli, and treatments in this group may also partially replace the functions of some part of an organ system, as in cochlear implants and prosthetic limbs. So your mechanisms of action would vary by the organ system, as well as the typical ingredients. So here are some examples of organ function treatments from the RTSS manual. I'm not going to read them, but it might help you better conceptualize these organ functions group if, again, we work backwards. So we're going in the opposite direction of the arrow. So we're looking first at the target, and we're asking what needs to change. So we want to increase the joint range of motion, similar to the example that Sue provided, where we're trying to increase dorsiflexion. So the mechanism of action would be increasing the sarcomere length, and the active ingredient would be applying force to a tight muscle, right? We talked about that plantar flexion stretching. So I'll note that some things that is sometimes confusing about the organ functions group is that it includes both passive and voluntary actions, or non-volitional and volitional treatments. So the other 2 treatment groups, which will be described next, are made up of only volitional treatments, which require active participation and effort on the part of the recipient. So you may be asking yourself, why not include exercise in one of those groups and reserve organ functions for passive treatments? Well, the answer is that exercises targeting the musculoskeletal or cardiopulmonary systems do not depend on information processing or learning mechanisms to exert their effects on the target. So with that in mind, let's dive into the next 2 groups to look at the different volitional treatment groups. So group 2, we have our skills and habits group. So the skills and habits group treatments include a large variety of treatments that have in common the mechanism of learning by doing, where learning is accomplished via repetitive practice and results in increased skillfulness of the behavioral routine. So a lot of what we consider training in the therapy world, such as gait training, ADL training, social skills training, training in the use of cognitive compensations, and many more would be included in the skills and habits group. And the typical ingredients we would see would include provision of opportunities for repeated practice, or use of instruction, use of cues, verbal cues, visual cues, tactile cues, guidance and feedback, such as knowledge of results versus knowledge of performance, as Sue mentioned earlier. So again, I'm not going to go through each of the examples, but again, I want to direct you to the target. So if our target would be to improve fine motor coordination for grasp, how does that happen? Learning by doing. And what are we what can we do to affect this change as clinicians? We can provide opportunities for repeated practice handling small objects of varied sizes. So the last treatment group is the representations group. So this includes treatments aimed at changing internal representations related to cognitions, affect, motivation, and intentions to perform volitional behaviors. So cognitions are referred to here as thoughts and ideas, whereas affect is used as a shorthand term to encompass both automatic and more reflective aspects of emotional experience and response. So motivation involves the propensity to act, and intentions represent plans to act. Your mechanism of action here would be cognitive or affective information processing, and your typical ingredients might include didactic instruction, prompts to process or prompts for action, and motivational techniques. I do want to pause here to just talk about this continuum of thought to action. It's important to note there's a range of targets in this group that reflects the fact that there is this continuum between information that is unconnected to action, such as knowledge for the sake of knowledge or reassurance to reduce anxiety, and information that is intended to lead directly to a specific behavior, such as a firm instruction to just do something. So at one end of this continuum might be patient education treatments, whereas the target is simply increased knowledge of one's condition. And at the other end might be a simple instruction to perform a behavior that is already within the client's repertoire, right? It's directed to a specific action. So then somewhere in between might be representation group interventions used to change attitudes, like using persuasion or the provision of various rationales to alter a patient's attitude toward engaging in less preferred treatment activities. So it is important to note where on the continuum, indicate where on the continuum of thought to action the target lies by considering whether or not the target directly involves behavioral change or a change in internal constructs such as belief, awareness, or attitude. And just to note too, it's important to remember that these action-related targets do not include repeated actions that are intended to develop skills or habits, right? Those would fall into the skills and habits treatment group. Next, thanks. So here again are some examples provided from the RTSS manual. If we take our case of Phyllis from earlier, who may not have enjoyed doing her home exercise program. She wasn't feeling motivated to do it, so a target might be to increase motivation to practice her exercises on her own time. Then the mechanism of action would be affective processing, and the active ingredient would be perhaps explaining the importance of practicing on her own time outside of therapy.
Were you done, Leanna? Sorry.
Yes, take it away, Susan.
All right, so talking about representations, Leanna mentioned Volition, and Volition is important in rehab, and so the RTS has defined Volition as the effort applied to the performance of an action, whether that's mental or physical or both. Now, when we scan the landscape of rehabilitation treatments, we see that the vast majority require volitional treatments. So as Leanna had mentioned, we do see volitional treatments in the skills and habits and in the representations groups, but in organ functions, volition is only required for some treatments. And that would make sense when you think that some treatments like TENS or medication or surgery or passive range of motion, they do not require volitional efforts. So volition is special because it addresses the lack of attempting to do an activity or engage in treatment. And thus, to be parsimonious, we are only paying attention to volition in terms of RTSS specification when we are not there to supervise the treatment, when we aren't there face-to-face or doing telehealth, because we can sort of encourage and change the way we present something if we are gauging any sort of disengagement. But in our case study earlier of Phyllis, the PT had given a home program, and so the PT would then set a Volition target so that Phyllis would complete the home exercise program, and the Volition ingredients would address that Volition target. What do we mean by Volition ingredients? Well, we mean things like special instructions or motivational messages or interactive reasoning between the clinician and patient to determine how therapy activities will be accomplished remotely. So this is just a good reminder of how important it is that we consider volitional ingredients to ensure sufficient motivation and ability to perform as directed. Now, in terms of applying the RTSS, we think that it has potential impact in these 3 practice areas, and we'll start with clinical practice. We believe that the treatment specification can improve communication, and within disciplines, a good example of this could be in coverage sheets, so that one clinician can communicate what targets and ingredients they were last working on. Interprofessionally, we could see improved treatment consistency among team members. And then across rehabilitation settings, we hope to see better continuity of care because the targets and ingredients of each settings, I guess, care plan would be disclosed before and after a transition, and that would result in better carryover. So bottom line, we think the RTSS has a role to improve clinical efficiency among disciplines, and that can help contribute to improved quality of care. Now, we do have to disclose some caveats and opportunities. The caveat is, as much as we love the RTSS, we must remind you that the RTSS will not identify the correct target or ingredients for you. You still have to do the work of using theory and evidence to guide your selection of treatments. But if you are ever stuck on, say, a challenging case where the patient is not making the progress that you had thought he or she would, you might find yourself using the RTSS and asking certain questions like, do I need to change the ingredients or change the intensity? Is my client's volition an issue? So the RTSS may be useful for problem solving and reflecting on challenging cases. And that's a good place to start if you're new to RTSS. Now it's time for you to practice applying the RTSS. We're going to show you a video case of a man who's post-stroke and receiving therapy in inpatient rehab. And we're only going to show a minute of it, but we want you to focus on what targets do you think the therapy is addressing and which treatment ingredients can you identify per target. And here's a worksheet for you to just envision like what we're looking for. You see the treatment groups on the first column, and then we'd like you to focus on targets and ingredients. We're not going to worry about mechanisms of action right now. So hold on while I stop sharing and switch to YouTube. Let's see if we can see this.
Oh, straighten out that, oops. Or real pumpkin. Maintain that grip. Good. It's just as bad. Okay, straighten out that elbow, straighten it out. Good. Keep in line with the whole edema management we're doing. Good. We're doing some pumping by you grasping and releasing. I really do want it to be somewhat above the level of the heart or elevated. squeeze. Come back down. Let's try the strawberry. Good. Squeeze, squeeze, maintain that grip. Go, 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 go. And back down. Good. Reach for the pineapple. Straighten out that elbow, extension, extension. Go, 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 and open. And when you do it, really exaggerate movement so we get some real strong pumping. Squeeze, squeeze, squeeze. Go, 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 go. Go, 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 go. Straighten out that elbow. Release, release, exaggerate that movement. Beautiful.
Okay. Let's,
Squeeze it, squeeze it, squeeze it. Maintain that grip. Go.
okay, let's go back. Okay. All right. So if you have any targets or ingredients that you saw, go ahead and either type them into the chat or you can unmute yourself and speak. And it doesn't have to be by organ function, skills and habits, or representations if you just want to throw out a target. Or if you have a question, if you don't know if it's a target, you can ask that.
I heard her
Yes.
say to the client that she said out loud that they were working on reducing edema.
Yes.
So that was one target.
Excellent. And right hand function, grasp and release. Yes. And I like that really specific right hand function, grasp and release. And also, did you see some reaching going on, some targeted, no, shouldn't use the word targeted, reaching in certain directions, focusing on elbow extension. Okay, and then, so I'm gonna just show you, oh, I lost it. There we go. Here's an example of some targets and ingredients that we saw. You can see in organ function, we had hand edema and then reducing hand edema, and then also the co-contracting the right upper extremity shoulder muscles, working on motor control. And then in representations, she was doing some instruction about the mechanisms to reduce hand edema. And there are the associated ingredients. And then we still have one more treatment group, which is skills and habits. And we saw an increased accuracy of functional reach to target with the right upper limb. And there are the associated ingredients. And so it gives you an idea of how many things the therapist is doing. And we only saw a small sliver of this treatment session. So there are a variety of treatment components that we probably would see if we took the time to analyze the whole session. So in terms of applying the RTSS in education, we think that it would be valuable because the RTSS tries to get students to think about linking what they're doing, the ingredients, with the targets and how are they specifically delivering the interventions.
And so we think that if you use the RTSS in conjunction with case studies and client simulations, that could help students engender positive habits of clear description of treatment components, as well as evaluating whether the ingredients and targets are a good fit and they're aligned based on treatment theory. In terms of education, we also think that RTSS provides a nice structure for treatment modifications and grading. In fact, it can be helpful in clarifying treatment targets, specifically asking what are you addressing and in what way. And then in terms of modifying treatment ingredients, we can think about that whole list of ingredients, from cues and instructions to dose to prompts to enhance volition. And so we think the RTSS can equip students with the skills they need to critically examine and understand the process of therapeutic change. In terms of research, the RTSS can provide many benefits. I'm just going to highlight several here. Knowing the treatment and enablement theory distinction may help clarify research questions, because maybe your primary outcome measure is too far downstream and needs to be more proximal. The RTSS also gives guidance about framing dose in relation to active ingredients. And it can be very helpful for reproducibility of interventions, because how are you going to reproduce a study if you don't have the specific details about the intervention protocol? And then we also think the RTSS can help identify which of the treatment ingredients are most effective, and that is really important in comparative effectiveness research. Now, if you would like to learn more about the RTSS, we invite you to join our networking group, which meets monthly. And the link posted here has the information for joining our calls, and it's free. We also have some presentations coming up at the Spring Institute and annual conference at ACRM. And you can also follow us on Twitter at ACRM-RTS. Here is just an example of one of those presentations. On March 20th, there'll be experts giving a half-day instructional course on the RTSS, and that will include some hands-on practice specification activities. And if you have used RTSS or you plan to use it in the future, we'd appreciate your answers on this survey so that we can know how you plan to use it, and it will help us develop materials to, help further your work and use of the RTSS. If you didn't know, we offered the RTSS manual as a free download. You can use this link to get to it. And if the manual doesn't answer your questions, there's also an online Q&A form on that page where you can submit your question about using the RTSS, and we will respond within a couple weeks. So now we have come to the Q&A period, and if you have questions, go ahead and type them into the chat box, or you can unmute yourself and ask your question. And while we're waiting for questions to come in, I will share one page of resources. These articles were published in a special issue of the Archives of Physical Medicine and Rehabilitation, and so they might be helpful readings for you. Do we have any questions? or do you have any feedback or experiences if you have used the RTSS or heard of it before? You're welcome to share that with us.
Hello, I actually have a question. Hi, Sue. Hi, Leanna. So I had a question when you were kind of talking about the 3 different categories, like the organ, skills and habits, and representation. It depends on probably the treatment, but when you're thinking about like a language intervention where the goal is targeting like neuroplasticity of brain function. So say word retrieval, and you're working on a treatment that's directly related to strengthening the hypothesized strengthening the kind of neural connection for word access. Would that fall under organ, would you say? Because you're kind of the mechanism, given the mechanism is trying to change a structural component.
Right. Unless you're providing a lot of opportunities to practice. So yes, maybe the aim might be the neuroplasticity, but the direct target might be the practice for language development or acquisition. I don't know the proper term for the speech, for speech language pathology. But if you're, I'm thinking it might be skills and habits if it's the direct target and ingredient for the language development. Does that make sense? And the aim would be maybe more long-term, like thinking more enablement theory versus treatment theory.
Yeah.
I thought it would be representations. See, we have questions.
And this is common too when going through the specification that we, it's a constant back and forth discussion of where it could fall.
Yeah, I mean, I can definitely look at the manual, but I'm curious because I do feel like for some of the, like if it's an acquired language disorder, so it's not like a developmental, they're learning the language for the first time, but you're trying to restore function. But it's tough because you are providing repetition at the same time and likely giving certain types of feedback. So it's interesting. It's just giving me something to think through.
Yeah. And I also think, Carla, one of the things that I would think about is what is the direct target? Yeah. What you're hoping to achieve. And, you know, if your direct target is the skill of being able to produce these, you know, words or this language, that then would direct you more to skills and habits. But if you want this learning, then it would be representations. And it could be that, you know, that as Jessica said, you know, that could neuroplasticity be the MOA? Well, it could be, but it kind of depends on sort of what if you're directly targeting that organ function. And so that's one that, I mean, we continue to kind of talk back and forth about the mechanisms of action. Those are the trickiest parts. I think when you're first learning, that it's easiest to kind of think about, okay, explicitly, what's my target and what are my treatment ingredients? And my theory about why I think that's going to work. You can see how we were Leanna was more vague in terms of, well, we've got learning by doing or cognitive information processing, because there's so much that you can't observe. So, and with the plasticity, you know, neuroplasticity, you're not actually observing that per se. So it could be, yeah. These are challenging questions, but it causes us to think, and it causes us then to develop that theory of why we really think that our interventions may work, or how are we going to test the effects of our interventions more precisely.
Yeah.
Carla, I was going to say sort of the same thing, that I think I would think about what is the target first. I'll give you maybe an OT example, like dressing is almost certainly a skills and habits, and it kind of a little more obvious maybe. But if someone's had a stroke, they're doing, I mean, neuroplasticity's happened too. So is it organ functions? Is it skills and habits? I think it goes with the target. The target is I want my patient to dress more independently. That sounds and looks much more like a skills and habit, even though neuroplasticity might definitely be happening.
Right,
Yeah.
and I think the way to look at it too is think about like what's the measurable outcome. Like right now, we cannot have an objective measurable neuroplasticity just based on the confines of being able to measure something. So that's where I agree with the whole thought that it fits more under the skills and habits or the representations just based on what we can actually measure.
Right. Okay.
So I'm curious from other people who haven't said anything, if you have thoughts about whether you think this would be useful in your practice, in your teaching, in your research. I'm just trying to get a sense from people of, we've spent a lot of time thinking about this, but we're curious to know from others how you think you might be able to use the RTSS.
It looks like we also have a question from Brooke typed in. Do you envision utilization of the RTSS to support or demonstrate efficacy of rehabilitation treatments being studied in research for the neurologic population?
I would say yes, I think that work is happening. Lauren Wengard, actually at the Ohio State University, has talked about using the RTSS to better articulate interventions for stroke rehab, for upper extremity interventions. So that's certainly one area in which we are looking at that. I know Jared Van Stan has done some work in examining rehab treatments for vocalization and speech. So those are a couple of examples of how it's being used. I don't know if others have additional examples.
Thank you, Jackie, for your comment. And this webinar will be posted on our landing page for others to learn from in the future. And we thank you for attending. Any last questions or thoughts? Oh. I'm curious how you would envision this being carried over into the clinical world, thinking about the example you showed of the woman working on edema, grasp and release, motor control. That's likely just a few minutes of a treatment session. Yeah, and there's a lot in there. Including this in documentation seems it may be quickly become unwillingly given productivity requirements. Yes, and that is why I said, Kelly, you might want to just start with like a challenging case, or a case where you're a little unsure, because it's going to make you think through the targets and ingredients in your treatment theory. So I do think, for a case study, I think it would be useful to use this. Has anyone used the RTSS in the way Kelly's talking about in the clinical world? Oh, okay. Brooke asks, are OTPT academia exposing students to the RTSS? Sue and Leanna, you want to talk about that?
I certainly introduce it in my movement kinesiology class at the MGH Institute of Health Professions, and we use it also in talking about interpreting research in our Research 1 class and in my Rehab Technologies course when we're evaluating the effectiveness of different robot-assisted therapy protocols and really looking at identifying what are the ingredients, what are the direct targets of these interventions. Here's just a few examples.
Yeah, and it's being utilized in speech programs as well. And then at SUNY Buffalo, I believe, for the PT program. Mm-hmm. So they are being utilized in across the disciplines.
Yeah. And Matt Geddes in Texas has also been using it in his OTD program, an MSOT program.
Yeah, I'll just speak that the students really responding to it well. It gives them a real something to hold on to understand and make clinical reasoning decisions and weigh things against each other and what could be better or not quite as good depending on the situations. And it is complicated. They do take a little while to ramp up. We've put it in across our whole curriculum, and but they really are able to think much better using some framework like this. And so I think hopefully we can get that out into field works and clinicals and get into the clinical world a little bit that way too at some point.
And I guess one other point that I think of in response to Kelly's clinical application is I think that the big thing that I take away from this is that it causes me to explicitly think about and articulate what I'm doing in my interventions. And it's the explicit process that helps you to decide what works or what's not working for your patient's progress. And so that if you just take that one piece out of this to the clinic, I think that it's helpful in terms of guiding you to using this as a first step.
I also think, this is Amit, and I'm a faculty at the University of Pittsburgh in the OT department. I've been using this framework to develop interventions for my research protocols as well. So like looking at, what's deficit that is there, and like going back to the drawing board with that, right? And then looking at it, like, okay, what are the active ingredients that are required? How are each of these active ingredients, what's the mechanism of action of each of these active ingredients? And when we want to develop, because our rehab interventions are complex and there are more than one active ingredients working, right? So using this framework with the target and mechanism of action, tracing back to the active ingredient, and then titrating it in a design for research where you can then funnel through or narrow it down, which is the most active ingredient, important active ingredient, most critical that's required in my treatment package, to making it more specific with that, and then dosing and all of that. So I see a lot of value of this framework in that as well.
Wonderful. Thank you for sharing. We have some great ideas on the chat box, and I think we are all on the same wavelength, which is great. So I just want to acknowledge that we do have we have had funders in the past. Why does that always happen? We have to thank our previous funders, NIDILRR and PCORI, Patient-Centered Outcomes Research Institute. And so they have paved the way. And we also want to thank you for attending our webinar. And we're glad to have shared this evening with you, and hope you have learned something. And we hope to see you at another ACRM event in the future. Thank you all. Good evening.